Good afternoon, everyone, and welcome to this ENDO-ERN webinar. We'll just wait a few minutes as people filter in. We're delighted to have such an array of experts to join us today and share information with you. I'm Amy Casey, and I'm the Communication Manager with ENDO-ERN, and we have a great program of rare disease webinars ongoing throughout the year. If you're not able to attend the webinars, I encourage you to always register because we send the recordings afterwards, and you can see the recordings on our YouTube channel. There's over 70 previous webinars available to help you with your rare disease understanding. Today, this event is chaired by our MTG6 chairwoman, Nienke Biermasz, and I'll be handing over to her in a moment. I just want to do some housekeeping with you. It's a very packed agenda, and there will be a very nice discussion at the end amongst Evangelia and Paul van Trossenberg from Amsterdam. But should you have any questions at any moment, please put them into the chat, and I will share them with the experts. We won't have the opportunity for you to ask directly, but you are more than welcome to put your questions into the chat. With that, let's get to it. I'm going to hand over to Nienke. Thank you, Nienke.
Thank you, Amy. Well, I'm Nienke Biermasz. I'm the adult chair of the main thematic group 6, pituitary of the ENDO-ERN, and I'm really happy that we can offer today this very interesting webinar on congenital combined pituitary hormone deficiencies in Europe. And of course, this is one of the the congenital hypopituitarism is one of the sub-themes of main thematic group 6. And Professor Christesen was one of the driving forces to have this topic on the agenda. And till now, we did not have so much congenital hypopituitarism webinars in our program. So I think it's really interesting, the program that was composed today. And I want to hand over to Professor Christesen because he will introduce the topic and the outlines of the webinar today. We will convene later on with an open discussion.
Okay, thank you, Nienke. I'm Henrik from Odense, Denmark, and I'll give you a short introduction to this and show the outline of the webinar at the end. I'm very excited about this topic. We just diagnosed a 9-day-old neonate 2 days ago with this disease, having a blood glucose of 0.0 after 6 hours of age as the presentation. So it's hot for us. Key facts about congenital CCPHD. It can be defined as at least 2 pituitary hormone deficiencies, and it should be not acquired. Genetic causes are identified in various proportion, 20 up to 40%, but there can also be fetal environmental events or factors like severe infections involving the brain. But still, there are a lot of unknown causes. It's not so rare if you also take those who are late presenters in account. And we have seen it as fruitful to split the disease into early presenters below 1 year and late insidious presenters after 1 year of age. There are a number of syndromes involved, but of course not all are syndromic. Just a short look at the pituitary gland embryology. It's developed from the oral ectoderm and the neural ectoderm regarding the posterior lobe. And genes are closing and opening in a cascade through the fetal life. And that drives the correct formation if there are no mutations. And here's a short cartoon about the complex genetics, what happens there. And I look forward to hear Mehul Dattani go into more details about this. The clinical manifestations, as I mentioned, are 9 days old, presented with very severe hypoglycemia after only 6 hours of age. But others are identified later with failure to thrive in the neonatal period, prolonged conjugated jaundice, or hyponatremic dehydration. Males will often present with hypogonadism that can question the sex of the child. Late onset patients follow the normal rules for deficiencies. I will not go into details for this. The late onset are also often with a gradual increasing number of hormones involved. Growth hormone deficiency is usually the first hormone involved. Here is from a cohort from Germany that you see that the longer time of follow-up, growth hormone deficiency will be followed by other hormone deficiencies. There are a number of syndromes associated to CCPHD. I will not call pituitary stalk interruption syndrome as a real syndrome. It's just that the pituitary stalk is hypoplastic or aplastic. But if you also include the chiasma opticum, you will have blindness or reduced vision together with CCPHD. And that's a syndrome that we can consider and always must consider in these children. But syndromes can be more than just midline brain defects. Very often corpus callosum is hypoplastic or with agenesia with various consequences. But there can also be cranial midline abnormalities like a cleft lip, single maxillary central incisor, or even just one central eye, cyclopia. The brain can be, the brain lobes can be more or less involved to the very extreme alobar holoprosencephaly, which is absolutely lethal within just a few minutes or hours after life. Other syndromes can involve a lot. One well known is Pallister-Hall syndrome, where you can have especially 6 fingers and toes, and a hypothalamic hamartoma, which is a malformation, not a tumor. And there can be other malformations in the epiglottis, the anus, the genitals, and there are a lot of other syndromes that you have to look for to be able to manage best possible. This was my short agenda. We'd love to hear from Mehul about the genotype-phenotype correlations next. Then we go to the Finnish pediatric cohort by Taneli Raivio and the French protocol for adults and children presented by Castets and Thierry Brue. Then we go to the Danish national cohort presented by 2 medical students. One was only former medical student, Louise and Cecilia. And then we have hopefully 5 minutes left to an open discussion and closure by Nienke again. Thank you very much.
Can you hear me?
No. Yes.
Yeah, sorry, I'm just trying to get it up to the presentation mode, so forgive me for a minute. Right, can you still see my screen, yeah?
Yes, you're
Okay.
in presentation mode. Thank you.
Okay, okay. So I think you've already heard a little bit about hyperpituitarism, and it refers to deficiency of one or more hormones produced by the anterior pituitary or release of the posterior pituitary. We're going to talk mainly about the anterior pituitary today because more is known about that, although we're beginning to get insights into the posterior as well. And you've heard about the incidence, which is about 1 in 16,000, and that's from a very nice study from Finland, which you'll hear about later on. But it's generally in that region in most studies. And you've also heard about the phenotypic variability. The hormone deficiencies can be isolated or they can be combined, or they may be syndromic. And you've heard about some of the syndromes, and we'll go into a bit of detail in a few minutes. So The important thing to realize is that this condition is associated with evolution of the pituitary deficits, and this can be very variable in terms of its onset, its severity, the combination of pituitary deficits and the pattern of evolution. And indeed, Manuela Cerboni, who was my PhD student and is now my colleague at Gosh, has described over 70 patterns of evolution of the phenotypes. But we're not only talking about pituitary deficits, these are complex disorders. So these children have significant neurocognitive impairment. They can get autism, which can be very severe, sleep disorders, hypothalamic obesity, visual impairment, seizures, and a host of extracerebral phenotypes. So Henrik's already talked you through a little bit about the pituitary development, but essentially it centers on the relationship between Rathke's pouch, which is derived from the oral ectoderm, and the neuroectoderm here, which is opposed to the oral ectoderm, and that's critical for the normal formation of an anterior pituitary gland. And this is what the gland looks like here, the normal anterior pituitary, the stalk, optic chiasm, corpus callosum, and the posterior pituitary is the bright spot there. And now we know that there's a cascade of genes that are important from a single stem cell right through to the differentiated cell types, and it's getting more and more complicated. There are early developmental genes, such as SOX2, SOX3, HESX1, etc., which give you pleiotropic phenotypes, not just the pituitary. The genes implicated just in pituitary development, PROP1 and POW1F1 are two examples, and there are genes involved in G8 secretion, two examples there, the growth hormone gene and GHRHR. And all of these can be abnormal and lead to phenotypes. And how did we find these genes? Well, initially there was a candidate gene approach using mouse models, which may be naturally occurring, such as the PIT1 and PROP1 mice, or transgenic models, such as the HESX1, LHX3, LHX4, and SOX2. And then there are chromosomal abnormalities in patients, which lead us to the right gene, and genome mapping strategies. But now that's all being surpassed by whole exome and whole genome sequencing, which is now used internationally. And so I'm going to talk a little bit about next generation sequencing and give you a few examples of how that's led us to find the right gene in some unique families. And this is a collaboration between Taneli Raivio, who's going to talk in a few minutes, and ourselves at Great Ormond Street. So he had a pedigree of two children, one of whom sadly passed away, the little boy, who had a complex phenotype with hypopituitarism and a communicating hydrocephalus. And he had an absent anterior pituitary and ectopic posterior pituitary. His sister had another phenotype which is related with an absent anterior pituitary and EPP, but also retinal dystrophy, abnormal teeth, scoliosis, and craniofacial dysmorphism. And then we had this girl who presented with short bones, midline brain changes, and craniofacial dysmorphism. And she was given the title oral facial digital syndrome, basically. She had polydactyly, a very small anterior pituitary, and a Joubert-like MRI cerebellar finding. So Joubert is a ciliopathy, essentially. And she had growth hormone deficiency, basically, with good response to growth hormone treatment and developmental delay. She had a brother who was conceived, but unfortunately had a lot of abnormalities, which may be related, and the parents opted for termination. And so you can see these two pedigrees, and we found a mutation in this gene called TBC1D32 in the two laboratories. So this is the Finnish boy, his sister, and then our patient here. And we looked at the expression of this gene in human embryonic sections, which we have available, and we found that it was expressed in the hypothalamus and in Rathke's pouch at certain stages of development. And this is a ciliary protein now, which plays a role in cell polarity determination, and it mediates other signaling cascades, most importantly the sonic hedgehog pathway, which is very important in pituitary and hypothalamus development. And knockout of this gene has led to deficient sonic hedgehog and deficient GLI2 localization within the cilium. And GLI2 mutations are commonly found in patients with hypopituitarism. So this links the ciliary pathway with the sonic hedgehog pathway and GLI2. And we found mutations in other ciliary genes, and that's a big area of interest in our lab at the moment. This is another collaboration, and this is a collaboration with a Turkish fellow, Leyla Akin, who came to our lab and brought 5 different pedigrees with ovarian dysgenesis in the girls, or ovarian insufficiency, and growth hormone deficiency. And the boys all had growth hormone deficiency. The girls had growth hormone deficiency plus ovarian insufficiency. And we found a homozygous mutation in this gene called RNPC3. And it was the same mutation in all of those 5 families. Subsequently, the collaboration expanded to Spain with Jesus Argente, to other areas of Turkey, to the USSR, to Russia rather, with Anatoly Tulpakov, and to Italy with Mohamed Magni. And these patients all had different mutations, one common heterozygous mutation. So what's this gene do? It's basically a spliceosome gene. So there are 2 types of spliceosomes that catalyze splicing of pre-messenger RNAs. The U2 type removes U2 type introns and accounts for over 99% of pre-messenger RNA introns. The minor U12 type spliceosome removes U12 type introns and is present in 700 to 800 genes, and it contains of several small nuclear RNAs and associated proteins. And RNPC3 is one of these proteins which forms part of the spliceosome. And basically, it had been previously associated with isolated GHD, but we've now shown that these children have other forms of hypopituitarism with low prolactin and TSH deficiency. They also have a peripheral neuropathy. The growth hormone response to GH treatment was excellent, but interestingly, in 3 boys, growth hormone was stopped and they continued growing in spite of being growth hormone deficient during the pubertal years. And males have normal pubertal development, unlike the females who have ovarian insufficiency. And the last example is this boy who came to me several years ago, and I've been looking after him for many years. He sadly passed away in COVID at the age of 26 years. And this photo was taken at the age of around 20 years when he was about 127 centimeters, complex phenotype with panhypopituitarism, hypoparathyroidism, retinal dystrophy, and developmental delay amongst the features. He had a high triglyceride at all times that were tested, a small anterior pituitary, and a failure to respond to GH and to IGF-1. And we eventually found a heterozygous de novo variant in fatty acid synthesis and looked at his fibroblasts and found that he had abnormal fatty acid metabolism, basically. So a metabolic gene accounting for a very complex phenotype. And we know that this gene is very important in the brain, in stem cells, basically. So to summarize our cohort, we have nearly 2,000 patients now that we've looked at with a range of phenotypes. And overall, you could say it's disappointing that the incidence of mutations is quite rare, greatest in those with severe eye defects or those with isolated GHD, but actually also exciting what's happening in the rest of the patients. So we took 81 patients then from 52 pedigrees who had unusual phenotypes, and we found variants in 26 variants in 35 patients so far, of which 22 were in novel candidate genes and 4 in the cartoon that we would suggest as an algorithm, but it will become out of date very quickly, I'm sure, and this was published in Genetics and Medicine a few years ago. And this is a range of genes that have been implicated in hypopituitarism, but it's expanding, and I'm sure we'll hear a lot more in the next few years. And these are the new technologies that are going to help us. So cell formation of the pituitary in culture, single cell transcriptomics, which allow us to identify new genes by expression studies. The hypothalamus, there's a lot going on in there now, and we believe that the hypothalamus has affected many of our patients. So I think it's an exciting time for the future. And just to conclude, these are pleiotropic phenotypes. What is hypothalamic, what is pituitary remains to be established. Rare generally in terms of mutation incidence, but the incidence is variable in terms of inheritance and penetrance. So there may be other genes, there may be oligogenic inheritance and environmental factors. And these phenotypes can evolve, especially things like PROP1, but even GH1. And any changes need to be carefully interpreted. Novel pathways are emerging, and we've just done the 100,000 genome study, and that's showing us some interesting insights as well. But above all, care with genetic counseling is required. And I'll finish off with this slide, all the collaborators, all the people I've worked with, and all the people in the lab who do the hard work, and all the patients and their families. So thank you very much.
Well, thank you, Mehul. Well, if there are questions, please put them in the chat for now. We will discuss it at the open discussion later on. I would like to move on. Taneli Raivio, I'm sorry, maybe I pronounced it wrong, but Finnish pediatric cohort. Very curious to find out what you want to tell us.
Taneli, have you been able to project your slides?
Actually, no, this share function doesn't seem to work. So
Okay, let's try it one more time.
so yesterday it worked, or on Monday
Yeah,
it worked.
let's try
So
again.
it works, but I don't know what to select from it. So that's because
Pick your full screen. It's the third one on the right-hand side.
okay. Well, it won't accept the selection.
Okay, I'm going to try it one more time. Oh, there you are.
Okay.
We see it.
Yeah. So this is in
Great.
the correct mode now, right?
I believe so. Will you just click forward one time?
Okay. So you
Yes, we're
see
good to
the
go.
slide changing.
Yes,
Okay.
yes, that's great. Thank you
All
so
right.
much.
Thank you so much for this opportunity. So I'm referring to this paper which we published a few years ago, which is entitled as Presentation and Diagnosis of Childhood Onset Hypopituitarism, a Single Center Experience from over 30 years. And this is my disclosure slide. And this is how we formed this study or the cohort. This was a chart review study, mostly a chart review study covering the time period from 1985 to 2018 in the Helsinki University Hospital. And here you can see just wait a second, you can see here the where we started, how we formed the cohort, which is shown down here. And this we have 124 combined pituitary hormone deficiency patients included in the analysis, and 61% of them had acquired form due to brain tumor, idiopathic or other reasons, and then congenital forms in 39%. And here you can see the idiopathic form, and the percentages refer here to the whole number of 124. Then there were genetically verified 7 patients, and then there is, as mentioned before already in this webinar, there were also syndromic patients with a known syndrome, but without genetic diagnosis. So here is shown in these two panels, here are shown the age at presentation in the left hand side here, and here is for the acquired form in this gray box plot, and the congenital form in the open box plot here. And on this panel B, there is the age at diagnosis. And as you can see, the median age at presentation for congenital CCPHD was 2.5 years, as shown in here. And the median age at the diagnosis was 3.9 years. And these were both significantly and, of course, expectedly younger than those with the acquired form. That was pretty self-evident, maybe. So the phenotypic features of congenital CCPHD shown in here. So 30% of the patients had deficiency in all anterior pituitary hormones, and approximately 20% had deficiency of growth hormone TSH, and the combination of growth hormone TSH and gonadotropins in 17%. And concerning the MRI findings, there were like 90% had a classic pituitary findings there, and there were also additional MRI findings, so it's very helpful in establishing the diagnosis. And also the patients had also extra pituitary phenotypes, mainly craniofacial, eye-related, and also developmental delay or epilepsy. Even almost 40% of the patients had those. The growth in congenital CPHD is shown in here for two different groups. So the left panel shows the growth deviation or the deviated growth in those who displayed it already during the first 6 months of life. Here and here who presented with growth deflection after the age of 6 months. And in Finland, we screen quite vigorously children's growth, and the median delay between the first violation of the growth screening rules and the initiation of growth hormone therapy treatment among all congenital CPHD patients was 2.2 years, which is debatable if that's acceptable or not. Considering neonates, this Venn diagram shows the clinical signs of congenital CPHD in a neonate, and as you can see, the three important phenotypic cues. Hypoglycemia is shown in here, and this especially prolonged hypoglycemia there with 23 patients, and 17 patients had prolonged neonatal jaundice, as shown in here. And then male patients, 8 of those presented also with a neonatal genital phenotype, which can be called as a hypogenitalism here. Importantly, only 3/4 were referred to the endocrine unit during the first year of life. So a better recognition and early and prompt diagnosis is required. Then we were able to also estimate the incidence and molecular genetic diagnosis of congenital CPHD in Finland, and because Finland is the land of registries, we were able to consider how many live children were born in the Helsinki University Hospital catchment area, and here you can see the little more than 400,000 during this time period, and 26 patients born in this region during the same period were diagnosed with congenital CPHD, giving an estimate on 1 to 16,000 live-born children. And here is the 95% confidence interval for this estimate. In our cohort, 7 patients out of 48 with congenital CPHD had a molecular genetic diagnosis, giving an estimate of 15%. And we also carried out a separate sub-study and evaluated molecular genetic diagnosis in 25 patients, but didn't reveal new molecular genetic diagnosis, although one patient had a likely pathogenic variant in sonic hedgehog, shown in here. So to conclude, the incidence of congenital CPHD in Finland was 1 to 16,000. The neonatal recognition requires clinicians' attention, especially the cues of prolonged hypoglycemia and jaundice, and also in boys, the genital phenotype are something that should facilitate thinking of this diagnosis. And later in life, growth deflection offers an important phenotypic cue. We are not currently screening CPHD in Finland. And also, once making the diagnosis, patients with CPHD frequently harbor phenotypic cues, especially related to eyes, craniofacial area, and psychomotor development. And MRI offers highly relevant further cues for once doing the diagnostic workup. Only 15% of patients with CPHD had molecular genetic diagnosis, so the work that Professor Dattani just presented us is highly welcomed, and this underlines the need for a high degree of clinical suspicion and further development of precision diagnostics. Thank you for your attention.
Well, thank you, Taneli. Yeah, so let's move on to the French cohort and the French protocol. Sarah and Thierry from Marseille.
Hello, everybody. Can you see my screen?
Yes,
Yes.
but it's not in presenting mode. Now it is, yes.
Okay. Thank you for the invitation. I am a pediatric endocrinologist in Marseille in France, and I am a member of the Reference Center for Rare Pituitary Disease with Professor Thierry Brue that you will hear after that. So this is going to be an overview of the French Congenital Pituitary Deficiency Protocol for adults and children. This protocol is designed for GPs and for specialist doctors, and it provides guidelines for diagnosis and for patient management. It is freely available online, and it has also been published in English in 2 articles, one for children and one for adults. These guidelines were written by several working groups composed of different specialists from all over France. 5,861 articles were preselected based on keywords, and then the best available article on each topic were included based on quality criteria. And finally, 5,065 articles were selected for the guidelines. So I won't go into the details today. I'll just give you an overview of the structure of the guidelines and a few points for pediatrics. And then I'll hand over to Professor Brue for a few slides on adults. The first part of this protocol concerns diagnosis and initial assessment. In children, the guidelines emphasize that clinical signs are often non-specific, and in neonates, presenting symptoms can be extra-pituitary, for example, ophthalmological or neurological signs. Then these signs are very important for pediatricians to know and should lead to pituitary workup. Workup guidelines are provided for different age groups. Laboratory findings in neonatal period are particularly difficult to interpret. For example, low GH or low cortisol in spontaneous hypoglycemia are not very specific for hypopituitarism, while low GH level in the first 7 days of life is strongly suggestive of GHD. Of course, GH stimulation tests are contraindicated in infants. And for diabetes insipidus, copeptin can be helpful with specific thresholds for neonates and for children with polyuria and hyperosmolarity. In some, diagnosis of hypopituitarism is often difficult, and in the guidelines, the main message is that the diagnosis is based on a combination of clinical, laboratory, imaging, and genetic findings. The online protocol contains checklists of recommended exams at each age group with clinical exams, growth charts, screening for hypoglycemia in infants, imaging, laboratory tests, screening for complications, and neurological assessment. We recommend systematic genetic analysis with NGS panel of genes involved in congenital pituitary deficiency, and or array CGH, particularly for syndromic forms, and then whole genome sequencing if the first line analyses are negative. In the therapeutic management part, we provide hormone replacement recommendation for different age groups. Treatment objectives are to minimize symptoms, to normalize laboratory tests, to prevent complications. We recommend patient support immediately after the diagnosis with self-management education, with psychological support and a focus on quality of life, and in collaboration with patient association. We recommend social, educational, and workplace inclusion. And for example, the French guideline provides templates with guidance for patient management at school and templates for parents for the emergency treatment of children at risk of adrenal crisis, as shown here in French. Then the last part presents follow-up recommendation for different age groups with screening for complication and recommendation for specific situations such as transition to adult care, fertility, or older adult care.
Yeah, and going on just on a few words on adult specificities in hypopituitarism, because the objectives of the treatment are partly distinct from the children, of course. We are, especially as adult endocrinologists, focusing on quality of life and metabolism. Also, we have to maintain optimal metabolic and biochemical targets. We have to be aware of comorbidities and look for cardiovascular disease, for example, and be aware of hormone-sensitive cancers. There's a special issue regarding fertility, obviously, that should be managed by specialized teams. And those adjustments are specific for each treatment and require monitoring. Next. Next slide. Regarding growth hormone, the treatment is essentially followed on the basis of IGF-1, and the aim is to improve metabolic outcomes. Regarding thyroid hormone treatment, obviously all non-specialists have to be aware that the biological monitoring is based on free T4 levels and clinical symptoms and not on other parameters, not TSH. And for hydrocortisone replacement, there's a fixed dose of 2 to 3 administration that has to be adjusted to each patient's work and activity pattern, and with mainly clinical parameters as monitoring. And as to a gonadal replacement, it's also a lifelong replacement in many cases to preserve secondary sexual characteristics and libido. And next, and as was previously mentioned by Mehul and Taneli and Henrik, it's important to look for some congenital causes even in adults. And so we've been working on this over the past 3 decades, starting with this family with PIT1 mutations. Next. And next. And this was developed within the Gene Hypopit network, which was developed in France, but also in many other countries that send us DNA samples and clinical information on these patients, and which allows to do now NGS panels to screen for genes responsible for congenital forms. Next. So this was basically what we wanted to stress regarding this approach to hypopituitarism in France, is the list of investigators that have been involved in this endeavor. And with this, we thank you for your attention. Next. Thank you.
Thank you so much for sharing this French initiative. I think the NOERN has been looking at your approach and is of course also thinking about guideline to give some ideas about how to care and diagnose, but that's still in development, and your center, your country has been able to finalize this, which is very good. So we have the last presentation, and that's from the Danish national cohorts, 70 years of follow-up by Louise Kerskaert and Cecile Jensen. Well, the floor is yours.
Thanks. Can you hear me? And see my slides?
Yes.
Okay, perfect. So, hi, I'm Louise Kasper Jakobsen, and I'm from Hans Christian Andersen's Children's Hospital in Denmark. I would like to present to you our study on the I would like to present to you a study on the incidence of CCPHD in Danish children. After my presentation, my colleague Cecilia will take over and present our follow-up study on risk factors for adverse functional outcomes in the same cohort. So I have no conflicts of interest. CCPHD is defined, as we heard, as the loss of 2 or more pituitary hormones caused by prenatal or genetic factors. The incidence has previously been estimated in the Finnish study, as we heard, and it was estimated to 1 per 16,000 live-born children. The objectives of our study was to estimate the national incidence of children diagnosed before age 18 years and in 2 subgroups. One subgroup containing the children diagnosed before age 1 year, and the other containing children diagnosed at ages 1 to 17 years. And lastly, we also wanted to describe some clinical characteristics, including brain MRI and hormone deficiency characteristics. So we included all Danish children born in the period 1996 to 2020 who were registered with relevant ICD-10 diagnosis codes in the National Patient Registry or in local hospital registries. And thereafter, hospital files were reviewed to validate the diagnosis from uniform criteria. We calculated the incidence using background population data. In total, we identified 128 CCPHD patients out of almost 2,000 investigated. Of those, 116 were born in Denmark and diagnosed before age 18 years. As you can see, 1 in 4 was diagnosed before age 1 year. More than 2/3 were males, and the most frequent deficiency was GH, followed by TSH. Almost 90% had brain MRI abnormality. So we estimated the incidence to 10 per 100,000 births, corresponding to an incidence rate of 6 per million births per year. In subgroup analysis, we found that the highest incidence was seen in the 1 to 17 years age group, but that the highest incidence rate was seen in the age group diagnosed before age 1 year. This subgroup also had the most hormone deficiencies at diagnosis and at last follow-up, and also the most frequent, the highest frequency of abnormal brain MRI findings. So in conclusion, the highest incidence rate was seen in the subgroup diagnosed below age 1 year. However, the highest incidence was seen in the subgroup 1 to 17 years, underscoring the need for multiple pituitary hormone investigation throughout childhood and adolescence in order to detect late onset CCPHD. And that was my presentation. Now Cecilia will take over. And I think I need to press stop sharing, or no, it looks good.
Well, I have some trouble because on my computer I am not connected with the sound, so I cannot share my slide. Is it possible to get help from you to share my slides?
Yes, I will do that now.
Okay, thank you.
Okay.
Yes, okay. I hope you all can hear me. Hello, everyone. I am Cecilia, and I am a pre-graduate student from H.C. Andersen Research in Odense University Hospital, and I want to present the follow-up study called Risk Factors for Adverse Functional Outcomes in Congenital Combined Pituitary Hormone Deficiency Shift. Yes. Is it possible to shift the slides? Oh, yes, thank you. So in this study, we aim to describe the long-term clinical follow-up and do the same subgroup comparison as mentioned before. And then furthermore, we wanted to identify risk factors for functionality in a modified version of WHO's International Classification of Functioning, Disability and Health, and identify risk factors for neurological impairment and psychiatric disease. Next. Yes, so we extended the inclusion period until July in 2024. And then we conducted a hospital file review on all included patients. And at last, we allocated patients into functionality groups depending on their support needs, whereas groups 0 to 1 had no or mild difficulties in their daily living, and group 2 to 4 had moderate, severe, or complete difficulties in their daily living. Next. Yes, so the cohort now consists of 148 patients, and we had a follow-up after diagnosis on 9 years with a range from half a year to 27 years, but the median age at last follow-up was 17.7 years. Patients diagnosed below 1 year had a shorter hormone treatment delay, and over 3 times as many had hypoglycemia or micropenis at birth. 29% had a short stature at diagnosis, whereas 77% in the group diagnosed from 1 to 17 years had a short stature. However, looking at follow-up, the median distance to target height were minus 0.18 standard deviation scores, and there were no difference between the two subgroups. We also found 33 out of 89 investigated with genetic mutations. Next. Yeah, 75 patients were found with no or mild difficulty, and 73 patients were found with moderate or worse difficulties looking at functionality and their support needs. We identified genetic mutation as a risk factor for impaired functionality in group 2 to 4 with an odds ratio on 6.5, and we also identified abnormal extrapituitary finding on the MRI of cerebrum as a risk factor with an odds ratio on 2.8. Next. We found just under 60% of the cohort with at least one neurological impairment during the follow-up period, whereas over half of the cohort had either delayed development, psychomotor retardation, or mental retardation during the follow-up. Around 15.5% had a visual impairment, and comparing the two subgroups, cumulative incidence of neurological impairment, we saw that the group diagnosed under 1 year had a higher cumulative incidence at as young and elderly, but there were no significant difference between the two groups in the cumulative incidence. Next. But we did identify diagnosis under 1 year as a risk factor for neurological impairment with an hazard ratio on 2.1, as well as we identified genetic mutation and, not as surprisingly, abnormally extrapituitary MRI. Again, next. Then we found 29% of the patients with a psychiatric disease in the follow-up period, with autism being the most frequent diagnosis and no major difference in the two subgroups. Next. We identified male sex as the only risk factor for psychiatric disease with an hazard ratio on 2.3. And next. Next, yeah, thank you. So to conclude, in our study, we found that genetic mutation and abnormal extrapituitary MRI of cerebrum are risk factors for individual support needs and neurological impairment. We found that diagnosis under 1 year were associated with a higher hazard of neurological impairment and shorter treatment delay, and they had more clinical features at diagnosis. And then we have quality of life questionnaire data pending to be able to give a more holistic description of life with the congenital combined pituitary hormone deficiency. Yes, and that was all from me.
Well, thank you very much for the presentation. Interesting data. I think we can move on to the open discussion now. So there are some questions from the audience, but maybe Paul, can you open the discussion?
Yes, of course. Yeah, I'm deeply impressed by all the beautiful presentations, not only on the genetics and not only on the characteristics of the Finnish population and the Danish population, but I wonder how you should deal with the children, as nicely has been told by Sarah and Thierry, when they are pediatric patients or adult patients. But I'm very impressed, especially by the Danish data on neurodevelopment, and there have been a few published studies of neurodevelopment in young patients with congenital multiple pituitary hormone deficiency from the United States already in 2010, and recently from Israel by Alina German about a cohort, and Nadia Schoenmakers presented her data from the UK population at SP in Liverpool. And I see all these outcome data especially aligned. They are approximately the same. And what I find striking is the high percentage of children with neurological deficiencies or developmental delay. And I think that's a point to discuss among us from how do we deal with this and what can we do about it? Because it's a worrisome high percentage of developmental delay. So that would be my first question, and then we have a few questions in the chat already. So please, who will comment? Louise or Cecile or Henrik or Taneli or Sarah, do you want to say anything about? Yeah, Henrik.
Henrik, please.
Yes, based on our data, I think it's an important point that the hormone deficiencies were not an independent risk factor for neurological impairment, because in our cohort is well treated and seemingly early enough treated not to make a difference. So that's a success story for endocrinology. But the risk factors were genetic mutations and abnormal extrapituitary findings in the brain, and that I think goes pretty much beyond what we can correct or treat. We can only help and assist to ameliorate these causes.
Yeah, I think that's a valid answer. That certainly plays a role. That is what you showed in your data analysis. Yes. Sarah or Taneli, any comments on outcome that you observe in your patients?
No, thank you for this very interesting data. I think probably we don't have a systematic neuropsychological evaluation for each children, and probably it's not easily available everywhere. And I know that in our center in France, it's not so easy, and we don't always do it for everybody, but for children, we for who we are more worried. And maybe the first step would be to, as we have done it in the guidelines, recommend it for everybody, and then to propose guidance for those children. I don't
Yes.
know how is it in your countries.
Yeah, I think that would be a very good idea to have it standardized in your follow-up of your at least your pediatric patients. Then a question to Mehul. Mehul, there was a question about genetic testing. Is it worthwhile to retest children with a congenital hypopit that we have in our follow-up if they haven't been tested yet, or because there are new genes to make a next step to find out if there's a genetic cause, yes or no? What do you think from a clinical point of view?
Yes, I mean, I think it's certainly worth retesting now, given the new technologies, etc. The data are still difficult. I mean, I think, when we talk glibly about whole genome, whole exome sequencing, we're going to find a lot of variants, and that's what we're doing with our panel. And, you need functional assays, which are going to be the limiting factor here. Because they're expensive and they need time. But we will certainly find variants. There's no doubt about that. And as I said, we're finding more than one in some children in pituitary-related genes. So I think we've got to remember that up till now, it's been quite selective. The Sanger has been selective. You go for the gene you think is most likely, and in this condition, there's a lot of variability. And then
Yeah.
whole genome sequencing, the 100,000 genome project, when they come back with a negative result, they've only looked at a panel of pituitary genes, so nothing outside it. And I've shown you the spliceosome genes, the fatty acid metabolism. So I think it's going to be a very interesting field, but I think we have to keep a very open mind.
Yeah, sure. There are two
And maybe,
questions. Yes, sorry.
yeah, maybe with my head of the MTG chair, there is of course the opportunity to discuss cases by the CPMS system. We have a fixed slot every third Friday of the month, and maybe it is interesting to have potential cases with an undiagnosed disease, so experts can comment on ways how to proceed. So I would recommend that to the audience. That's really nice opportunity.
Yeah, and finally, there are two questions from the audience, and that's for Thierry, I think. And one of the questions is the cardiovascular risk increased in adults with combined pituitary hormone deficiency? Do we know anything about that?
Yes, yeah, there are a few studies that all concur in confirming that there's an increased cardiovascular risk, which is due to several causes intermingled between the different deficits that are present, gonadal, thyrotroph, or growth hormone deficiencies. So it's important to make sure that the patients have appropriate substitutive treatment, especially growth hormone treatment is also part of this. And so cardiovascular risk is also is characterized by insulin resistance, sometimes obesity, and also hypertension in this patient is more frequent.
Yeah, and a second question, but that's really part of the previous question is, do you maintain low dose estrogen treatment in women older than 50 to 55? Because is that something also to consider going on with treatment beyond that age in women with CPHD?
Well, in the guidelines, we decided against promoting prolonged estrogen treatment after the normal age of menopause. Although we just said that in this case, if some physicians want to use this approach, we should follow the recommendations that have already been made for general population about menopause.
Thank you. With respect to the time, I think, Nienke, I give the word back to you to make some closing remarks.
Yes. I think this was a great webinar. Very interesting topics. I think this added value of cohorts and what we can learn from cohorts, and well, for me particularly also the fact that new cases can be found, and that will tell us so much about pathophysiology and impacts of this disease. I think when there is transfer to the adult endocrinologist, the specific cases of congenital hypopituitary become a little bit into a field with the acquired conditions that are of course very challenging as well, but they don't have this extra pituitary pathology that we really should keep in mind, even if you are experienced endocrinologist, adult endocrinologist. And so I think this communication with the pediatric colleagues is very important here. And so I think it's really good to keep in touch. I want to thank all speakers, and I want to thank the audience. And this webinar will be recorded, so it will be available online, not immediately, but after a while. So thank you so much, and see you soon.
You.
Thank you.
Thank you. Bye.